99. And he is a well-known speaker, and he is on this hepatology field for so many years, and he is a great friend of ours. So welcome, Untitled, and let's listen what he is talking about. Thank you.
Mr. Dr. Daomi, Dr. Daniel, thank you very much for this kind invitation. I hope that my sarong will not fall off during my talk. The topic that I've been assigned to talk this morning is, can antiviral agent really prevent HCC? Who say Mahobo? Raise your hand. So everybody seems to agree with the treatment. Who say Ode? Okay. Now, I'm going to tell you the answer in the next 15 minutes. Each year, more than 700,000 new HCC occur all over the world. And 90% of these cases die because of the liver cancer. Unfortunately, you can see that 70% of these cases occur in Asia. Who gets HCC? As you know that most of the patients at risk are patients with chronic hepatitis B, patients with chronic hepatitis C, and also the patient with cirrhosis of any causes. And the risk may increase after age, male gender, and right now we know that diabetes is also a risk factor of HCC. Right now, we can prevent hepatitis B related HCC. With the universal hepatitis B vaccination, there was a significant drop in the incidence or prevalence of the chronic hepatitis B, such as from 16% to 1.4% in China, 9.8% to 1.3% in Taiwan, and 9.3 to 0.9 in Spain. And after the implementation of the universal hepatitis B vaccination in Taiwan, Professor Mai Wai-Chan demonstrated a 70% decrease in HCC incidence in the pediatric case. And this also confirmed by the randomized controlled trial from China. What mechanism that hepatitis B virus cause HCC? There are possibility that, as we know, chronic hepatitis B cause liver inflammation, and inflammation cause liver site injury and proliferation of the fibroblasts, have an effect to the host DNA mutation due to the hepatocyte turnover rate and cytokine and growth factor release. This stimulates the HCC. For the chromosomal integration of hepatitis B virus, the chromosome can instability and alter the gene expression and function, can also cause HCC. And for the protein X of hepatitis B, it interferes with the cellular transcription and signal pathway that will interfere and can cause HCC. If you look in another way, like a viral factor, host factors, and environmental factor. For the viral factor, as Dr. Hollinger mentioned before, high HBV DNA is a risk of HCC. Genotype C more common than genotype B. The chronic Hep B with the pre-core mutant, core promoter mutation, or if they have all negative, but they have a high S antigen level, they can also risk. For the host factor, male gender, increasing age, recurrent or persistent elevation of the liver function, cirrhosis, and diabetes are the risk factor. For the environmental factor, heavy alcohol drinking, smoking, alpha toxin exposure, co-infection of hepatitis C or HIV. These are all the factors that will stimulate HCC development. It has been known for nearly 20 years that the patient who have spontaneous E0 conversion or the patient have E0 conversion by the interferon treatment, they have a better survival, they have a less chance of HCC development. And this slide shows you the landmark study by Professor Yu Fan Liao, published in New England Journal 2004. In this study, Professor Liao recruited about 650 patients. And I can say that about 100 subjects from this study come from Thailand. In this study, there are two arms, lamivudine arm and placebo arm. All patients have significant fibrosis of at least F3 and have HBV DNA more than 0.7 milliequivalent per ml at that time. The study was planned for 5 years, but had to terminate at 3.5 years because of significant effect to the treatment arm. In the view of the HCC prevention, you can see that there is a significant drop from 10% to 5% comparing between the placebo arm and the treatment arm. I would like to thank Professor Anna Locks and her team that she have a very nice review last month published in Hepatology, and this saved my presentation a lot. And in this slide, she has a very nice job. And this is the meta-analysis of the randomized control trial, comparing any treatment of the chronic hepatitis B, comparing with no treatment. And you can see that the trend of the result towards to the treatment arm in the view of decrease the liver-related death, HCC development, turning to the cirrhosis or decompensated cirrhosis. Significantly better in the treatment arm of any kind, comparing with no treatment. This is another meta-analysis of the observation study comparing antivirus versus no treatment. And the same results coming. The treatment with the antivirus significantly decreased the death, development of the HCC, and also decompensated liver diseases. The early phase of this study used lamivudine as a treatment. And for the later stage, entecavir and tenofovir are the common medication that has been used. This is also another meta-analysis of the observation study comparing interferon versus no treatment in the chronic hepatitis B and compensated liver cirrhosis. You can see significant decrease in the death, the incidence of the HCC, and compensated liver diseases. This is a slide meta-analysis again, observation study comparing lamivudine to non-treatment in chronic hepatitis B and compensated cirrhosis. As you may see again, that significantly better in the treatment arm comparing to the control. This is a very good slide. Who will get most benefit from the treatment? This is a study from Hong Kong. On the left-hand side will be male, and the right side will be female, stratified by age. You can see that the patients who will get most benefit from the treatment are the patient age around 55 to 75, because in male, about 24, 16, 10% decreased chance of HCC. In females, this positive effect also happen, but not as prominent as in male patient. This is the same because we know that for the young age, they have good liver, they have not too much scarring, the chance of the develop HCC is very low. So if we treat them at that time, the chance to prevent HCC may not show us very dramatic comparing to when we give at the elder age. Now, this is the final, not the final slide, the slide that can be really prevent HCC. This slide is very nice. On the left-hand side of this graph, this is the patient who have the chronic Hep B compensated cirrhosis. The solid line is an E antigen negative, and the dotted line is E antigen positive. All receive nucleoside treatment and complete response. Complete response means HBV DNA less than 2,000 IU per ml. You can see that even their complete response, they can still have cumulative incidence of HCC around 10%. On the right-hand side, this is the E antigen negative patient, and the yellow color is inactive chronic hepatitis B. The graph is quite flat. For the inactive but liver cirrhosis, the red color, the line start rising up, and in patient with nucleoside analog treatment, complete response and chronic hepatitis B around less than 10%. But if you have nucleoside analog treatment, complete response, and you have cirrhosis, the chance is decreased but not diminished or zero. You still have accumulative incidence of HCC about 20%. Let's go to my conclusion that primary prevention in the form of hepatitis B vaccination has led to the significant decrease in the HBV-related HCC, but not zero. Permanent HBV DNA suppression, either by interferon or nucleoside nucleotide, significantly reduce the HCC risk, but not zero. So we still have to regular surveillance is recommended. Before I end up my talk, I would like to show you one interesting case. This is a 64-year-old man, non-hepatitis B E antigen positive for more than 10 years. He was started with telbivudine, 600 milligrams a day, and his HBV DNA was undetectable 1 year after the treatment. Before we start the treatment, his platelet is around 150,000, indicating that this patient with his age, long duration of infection, low platelet, he should have some significant fibrosis or maybe compensated cirrhosis. Fortunately, he developed E11 version 3 years after treatment and persistent HBV DNA negative. His son developed cirrhosis and liver cancer with the age of less than 30 years old. He followed up regularly with normal liver function, normal alpha-fetoprotein, and ultrasound showed no mass in the liver. The ultrasound in April last year showed parenchymal liver disease, alpha-fetoprotein 2.7. Last month, he met me. Ultrasound found 7 centimeters unified mass in the right lobe of the liver. Alpha-fetoprotein increased to 52, CEA 1.9, and CA 19.205. CT scan found mass, huge one, 11 by 12 at the right lobe, and also a small one in the left lobe. The portal vein, hepatic vein, and IVC are still patent. This is a CT scan of this case. So this is a 60-year-old man, chronic hepatitis B, liver mass, rising alpha-fetoprotein. Who think that this patient have HCC? Raise your hand. Who think that this is not simple HCC? Raise your hand. If you look at this CT scan, this is in the arterial phase because you can see dense contrast in the aorta. That this tumor is not very hypervascular tumor. And I don't have the slide to show you that in the portal venous phase there is no rapid washout. And when you see a lot of liver patients, the liver mass size 11 centimeters like this, majority of them usually have portal vein thrombosis. It's very unusual that 12 centimeters, the whole line lobe liver, patent portal vein. So liver biopsy was done. On the upper panel is the immunohistochemical staining. I have no idea, but I read only the interpretation from the pathologist, which is the hepatocholangiocarcinoma. Intrahepatic cholangiocarcinoma is a devastating malignant tumor arising from the peripheral intrahepatic bile duct epithelium. Hepatolithiasis, primary sclerosing cholangitis, liver fluke, fibropolycystic liver disease are the risk factor of the ICC. Some recent studies suggest that hepatitis B virus infection may play an important role in the ICC development. I picked one of these studies from Japan, from Osaka. It's a retrospective cohort study. Recruit more than 100,000 patients, healthy, aged between 40 to 64 years, with the observation period 7.6 years. The incidence of the ICC is about 0.88 per 100,000 per year. And when compared between the group with and without hepatitis B infection, there is a higher 8.5% increased risk of HCC in the group with the chronic hepatitis B infection. So after the review, there are many studies showing that chronic hepatitis B infection is also another risk factor of intrahepatic cholangiocarcinoma. So I bring up this point because the prognosis and the treatment is totally different between cholangiocarcinoma and the HCC. So you have to keep in mind that if something not straightforward, maybe we need a histological development, the diagnosis. If I have 1 minute, I just want to overlap to a little bit. The treatment of the hepatitis C is also the same, because if you can achieve SBR, you can also decrease the risk of the HCC, but the risk may not be zero. You will still keep surviving.